All right. How's everyone doing? Everybody's okay? All right. How's everyone doing? Yes, I know the feeling. It's almost over. Almost over, Rebecca. Almost over. How's the Vati going? Good, good. Good, good, good. Mm-hmm. So close. Yeah, med surge. Good. Good, good, good. So that way you can make sure you're looking at those PowerPoints. Make sure. Good. Yeah. Try to be 75% done. 75% there. All right. So guys, these PowerPoints are in the description box. So you can I put them here so you can have them. Yep, that's awesome, Miss Amy. Farm. Poof. I think you guys, if you hit that Vatty, you'll do great. If you stay in that Vatty. All right. Okay, so let's read the disclaimer. Oh, as I was saying, guys, the PowerPoints, they are in the description box. So when you guys are finished, you can go, you can get the get the PowerPoints, go through them, listen to this lecture a couple times because it deals with intracranial pressure. So you guys definitely will have intracranial pressure on your exams. So make sure you listen to this a couple of times. All right. So let's begin. All right. So FBI, federal law allows citizens to reproduce, distribute, or exhibit portions of copyrighted motion picture, videotapes, or video disc under certain circumstances without authorization of the copyright holder. This is called fair use and is allowed for purposes of criticism, news reporting, teaching, and parody, which doesn't infringe of copyright under 17 USC 107. So the views, thoughts, and opinions expressed in the text belong solely to the author and not necessarily to the author's employer, organization, committee, or other group or individual. All right. All right. So ICP, like Miss Amy was saying, there's a lot of questions on increased intracranial pressure. So tonight we're going to deal with just the monitoring. So tonight I'm going to just tell you guys, I'm going to tell you guys about the ICP monitoring. All right. So this will help also. So when you do get these, when you guys, because you guys are doing the med surge modules, you will see some ICP monitoring. It's a huge, huge deal. All right. So we'll do ICP monitoring tonight, and then Friday I'm gonna go over the Glasgow Coma Scale. So we'll do some scenarios with the Glasgow Coma Scale. All right, because that's one way. If you have a patient who has like a brain injury, head injury, meningitis, any of these situations, any system disorders that causes increased intracranial pressure, you have to know about the Glasgow Coma Scale. So we're definitely gonna do that on Friday. No, Monday. Monday. We'll do that on Monday. You have to know the Glasgow Coma Scale front and back. All right. You can't know ICP monitoring without knowing Glasgow Coma Scale. Okay. All right. So ICP monitoring, remember 10 to 15 millimeters of mercury. That's normal. 10 to 15 millimeters of mercury. So this patient obviously has some signs and symptoms of increased intracranial pressure. So this a patient has to go into a little more more invasive monitoring. All right, more invasive monitoring. So intracranial pressure monitor device is inserted into the cranial cavity. All right, so this one, an intracranial pressure monitor, is a device inserted into the cranial cavity. It's going to record the pressure and is connected to a monitor that shows a picture of the pressure waveform. So as a nurse, imagine you are there with the patient. It's going to be a one-to-one type deal, right? And you're going to be monitoring the pressure, and you're going to be monitoring the pressure waveforms. All right. So this patient had some type of brain injury. This patient maybe have meningitis. Something is going on with this patient. And this patient has increased intracranial pressure. So you can't take a chance. The facility, the physician no longer wants to take a chance with just our head to toe assessment. They need to do something more invasive. So they're going to do intracranial pressure monitoring. They're going to use different devices. Now, this slide, it says an intracranial pressure monitor is a device inserted into the cranial cavity that records pressure and is connected to a monitor that shows a picture of the pressure waveforms. So you guys are going to be the nurse monitoring the pressure and the waveform, and anything above 15 millimeters of mercury, you have to alert the physician right away. So basically, the exit and the board, they want you to know as a nurse when it's time to call the physician. So if it's anything above 15 millimeters of mercury, then you need to make sure you notify the physician right away. This procedure is rarely used unless the client is comatose. So there is a minimum need for pain medication and pre-procedure client teaching. So this patient is in bad shape, guys. This patient is in a coma. All right. These procedures are rarely used, but guess what? As a first year nurse, you need to know them. The board wants you to know them. As a first year nurse, the board wants you to know them. So these are the different types. This is the intraventricular catheter. All right. Intraventricular catheter. This is a monitoring device. This is inserted into the cranial cavity. It records pressure and is connected to a monitor. All right. So this is actually an intraventricular catheter device. Now, actually, there are quite a few here. I found an image of quite a few different devices just to give you guys a visual of how invasive this procedure is and why this monitoring can't go on for more than 3 days. All right. This is a high risk procedure. All right. They're actually going into the cranial cavity. All right. So that's the intraventricular catheter. And they have a subarachnoid screw or bolt also. So let's just take a look at this. There's a screw and a bolt. I'm going to go back up. There's a subarachnoid screw or bolt. Same thing. The objective is the same. You are monitoring. You're inserting a device into the cranial cavity that records pressure and is connected to a monitor that shows a picture of the pressure waveform. But this one, they're just using an actual bolt. They're going to use a bolt. And here's a picture again. This is a picture of, this kind of gives you an idea of the intraventricular catheter from a different, this is a different visual. So you see that's a device is inserted into the cranial cavity that records pressure and is connected to a monitor that shows a picture of the pressure waveforms. So this gives you an idea also how they can monitor intracranial pressure. All right, very invasive. So I want you to start thinking of infection control and hemorrhaging. Just imagine if you were taking care of this patient, you will be very vigilant about infection and hemorrhaging. Not only are you looking at the measurements, but you're also making sure that the patient doesn't have any type of infection or isn't hemorrhaging. All right. So this is an epidural or subdural sensor. You see the same objective. All right. This is just more a fiber optic sensor. Is inserted into the epidural space through a burr hole. So our objective, guys, our priority is to make sure infection control, hemorrhaging, and we are watching that monitor like a hawk. We don't want it to get above 15 millimeters of mercury and we're just sitting there. We need to make sure we call the physician because that's what a safe nurse will do. So why would I give somebody why would I have to have someone have one of these procedures? Why do I need intracranial pressure monitoring? Well, it's useful for early identification and treatment of increased intracranial pressure. So just say you had a patient that had some type of brain injury and he's here with you and you're noticing signs and symptoms of increased intracranial pressure just with your head to toe assessment. Because we as nurses, we don't have all of these devices in our pockets. We only have our assessment. So we're there with this patient and we're noticing signs and symptoms of increased intracranial pressure. So this patient will be a candidate for ICP monitoring based off our assessment. Clients who are comatose or have a GCS score of 8 or lower are candidates for ICP monitoring. So we always have that saying, less than 8 intubate. So you can imagine if someone has a Glasgow coma score of less than 8, that patient is also a candidate for ICP monitoring. All right. So coma, GCS score of 8. What are some other manifestations of increased intracranial pressure? So you're there with the patient, guys, and you're assessing the patient because remember, we don't have all of these tools. We don't have machines in our pocket. Based off our head to toe assessment, I'm noticing that my patient is showing signs and symptoms of increased intracranial pressure. So let's talk about some signs of increased intracranial pressure. These are some manifestations. All right. Basically, guys, this patient is going to have a lot going on. You're there with the patient and you're noticing that maybe the patient has pinpoint pupils or maybe the patient Glasgow coma scale has decreased. Okay. The Glasgow coma scale has decreased. So you're here and you notice that your patient was probably at a 9 and now your patient is at an 8. That's a sign of increased intracranial pressure, guys. I was reading about the Glasgow coma scale, and remember, on Monday, I'm going to give you an even better lecture on the Glasgow coma scale. But I was reading that there's mild, moderate, and severe. So a patient could be mild and go down 1 point and become moderate, go down another point and become severe. So even one little point, guys, 1 point for the Glasgow coma scale could change the severity of the patient's condition. So even 1 point for the Glasgow coma scale, I want you guys to remember, you need to act right away because remember, it could be mild, moderate, and severe. So if my patient was mild at 3 o'clock, goes down 1 point, he can become moderate at 4 o'clock. All right. At 5 o'clock, if he goes down again, he's severe. So when it comes to the Glasgow coma scale, guys, this isn't something that you're going to wait. This is something that you need to notify the physician right away. All right. This is an indication that the patient may have increased intracranial pressure. All right. So you definitely don't want to wait around for that. You need to let someone know right away. Another manifestations of increased intracranial pressure is posturing. You'll have a patient and you know that you did not put this patient in this position, decorticate or disseberate. Look at disseberate and remember celebrate because the arms are out. The arms are out. Disseberate, celebrate. The arms are out. Guys, if you have a patient that's posturing like this, you need to let someone know right away, let the physician know right away. It is a sign, a manifestation of increased intracranial pressure. This patient may have to do that invasive monitoring. If you know that you didn't put your patient in this position, you know that this is a manifestation of increased intracranial pressure. This is the corticate. Okay, this is an indication of increased intracranial pressure. Remember, we don't have that specialized equipment. We only have our assessment. So if I know I didn't put my patient in this position, my patient has a brain injury, my patient is experiencing signs and symptoms of increased intracranial pressure. So I need to call somebody right away. Cheyne-Stokes is also an indication of increased intracranial pressure. Cheyne-Stokes. So don't get it confused with Kussmaul's respiration, guys. This is Cheyne-Stokes. Okay, so Cheyne-Stokes. This patient will have periods of hyper respirations and then apnea and then hyper respirations again. So it's hyper respiration and then the patient will basically stop breathing. And then the patient will start breathing again. This is probably one of the reasons why the patient has to go on those invasive monitoring, all right, for increased intracranial pressure. No, it's not the death rattle. No, the death rattle is actually, it's like a rattle. A death rattle is, just imagine someone having phlegm, in the airway, like phlegm, and you hear it rattling, and it's brown. It's like a brown phlegm, Miss Michelle, Miss Spencer. It's like a brown, when it comes out, it's like a brown phlegm. The death rattle is like a rattle. It's not like Cheyne-Stokes where someone is hyperventilating, stop breathing, then hyperventilating. Miss Michelle, I'm gonna send you the actual video of someone in Cheyne-Stokes and someone who has the death rattle. Okay. All right. The death rattle is, it is not good. It's not good. All right. And this is the dilated. This is also an indication. If you know that your patient has brain injury, meningitis, or some type of trauma, guys, to the head, this is a bad sign. Look at this. This is a dilated pupil. This is a bad sign. So this is something that you need to call the doctor right away. This is why we're assessing for PERLA on our patients. We do our neuro checks for our patient with head injuries, because if I see this, I need to call somebody right away. There's nothing else that I can do for the patient. And these are pinpoint pupils. This is also a sign of increased intracranial pressure. So this is pinpoint pupils. So this may be the reason, the indication the patient needs the monitoring. So all of those things, one of those signs and symptoms occurred. So now your patient definitely needs some type of monitoring, more invasive monitoring. All right. Maybe you found the patient in the decorticate position or the disseberate position, or the patient has dilated pupils or pinpoint pupils. Okay, so now it's time for your patient to have that invasive intracranial pressure monitoring. Either it's the intraventricular catheter, the subarachnoid screw or bolt, or the epidural subdural sensor. One of the three. Okay, one of the three. So just keep in mind the patient's scalp will be shaved and it's going to be cleaned with antibacterial solutions. So I want you guys to really, when you antibacterial solutions, guys, I want you to really focus on antibacterial solutions because you will see them on your exit. They love to hit you guys with antibacterial solutions. Okay? These are like, that's like the chlorhexidine or betadine. Okay, they're going to use these things. This is what they'll use to give the patient, to clean the area, the betadine. But I also want you guys to know about chlorhexidine wipes also. All right. They will use some type of antibacterial solution to clean the scalp. All right. Because, this infection, if an infection goes to the brain, can you imagine the prognosis for that patient? So they're going to use a heavy duty antibacterial solution because this is the monitoring. This is an example of the monitoring. So you guys can understand why they have to use the antibacterial solution. They're going to shave the scalp and they're going to clean the scalp with antibacterial solution. All right. So this is what they do pre-procedure. Just remember, they're going to shave the scalp and then clean the scalp. Okay? Because this is what the patient has to have. So pre-procedure, remember, shave the scalp, clean the scalp. Now look at the betadine here, guys. Look at the betadine. All right? Shave the scalp and then clean the scalp because you definitely don't want any type of infection, any type of microbes introduced into the scalp at this time. Can you imagine if someone goes through a traumatic brain injury, comes out of it, and then now they have some type of bacterial infection of the brain? So we have to, as nurses, this is our priority to make sure that there's no type of microbes or microorganisms introduced into the brain, guys. So remember, shave the scalp and then they're going to clean the scalp with an antibacterial solution. All right. Intra procedure. So imagine you are a nurse, you are there with the patient, you are there during this procedure. You're staying with your patient. He's your patient. You're going to stay with the patient. You are always assessing the Glasgow Coma Scale. All right. Always. You're always looking at your patient and you're always assessing the Glasgow Coma Scale. You always want to know the level of consciousness. You have to be the voice for your patient. So remember the Glasgow Coma Scale and come back on Monday to get the lecture for that. So this is intra procedure, the Glasgow Coma Scale. And also, very important, surgical aseptic technique. You guys know that if you're going to do this type of procedure, this invasive procedure, guys, surgical asepsis, okay? No bacteria. All right? We have to make sure that we're keeping our patients safe. It's from bacteria and from hemorrhaging. And we are always assessing the level of consciousness using the Glasgow Coma Scale. All right. Post-procedure, nursing actions. Guess what? We want to maintain the system's integrity at all times. If you're the nurse taking care of this patient, you are maintaining the integrity of the system. You don't want any system contamination. All right. If any type of infection is introduced into the brain, guys, that's a life-threatening infection. So post-procedure, guys, we are maintaining system integrity. We are making sure that there's no system contamination. And guess what? I'm monitoring that site like a hawk. I'm monitoring this site like a hawk, guys. After the procedure, I am looking for any type of swelling, increased redness, increased drainage. I am monitoring this incision for swelling, drainage, redness, increased redness. Okay? I am monitoring this patient like a hawk because I need to make sure there's no type of infection introduced. Okay? I'm going to make sure that the system remains closed, because this is a closed system, because we don't want any type of contamination. So I am making sure that this is a closed system, just like with my chest tube. Okay. And I am monitoring the pressure should not go above 15 millimeters of mercury. All right. And I'm doing my neuro checks. Okay. I am doing my neuro checks. So I'm going to say that again. Oh, yes. There's going to be plenty of questions. So I'm going to tell you guys again. If I'm taking care of this patient, post-procedure, infection, making sure that this system remains closed, I'm looking at the site for swelling, drainage, any type of increased redness. Okay. And I am monitoring, making sure that the intracranial pressure does not go above 15 millimeters of mercury. All right. So how do I interpret this? Like, what am I looking for? If I have a patient who has an invasive procedure, or they have this invasive procedures like intraventricular catheter, if my patient has a subarachnoid screw, if my patient has epidural subdural sensor, what am I trying to interpret? Well, guys, it's very easy for us. At this point, we're just trying to make sure that that ICP does not go above 15. So you guys see that there. You see this guy is at 12. So he's good to go, right? Because he's at 12. I definitely don't want it to go above 15 millimeters of mercury. So this is what I'm monitoring. This is the findings. This is the goal. They are using these catheters, these screws, these bolts, these sensors, and I can read it as a nurse. I can sit there and I can read ICP is 12, and I'll document that. I don't want it to go above 15. All right. And what are the major complications of inserting these things? Well, think about it. What could be a major complication? Infection. Infection is the major complication. So we have to be very, very strict. We have to use strict aseptic, surgical aseptic techniques. We have to keep this drainage system closed. And guys, after 5 days, you need to let the doctor know it's been 5 days. Okay. So that's our biggest thing. Limit monitoring 3 to 5 days. Make sure you keep this system closed. You are monitoring for infection. You are monitoring for bleeding. And if you can do that, guys, if you can do those things, then your patient will be safe. So just a quick recap. All right. Let's go back to the top. All right. Make sure that you guys remember for your exams. All right. Make sure you remember the range. You know, the lab value, 10 to 15 millimeters of mercury. We don't want it to go any higher than that. All right. If you have a patient who has signs and symptoms of increased intracranial pressure, just know that the physician may have to do things more invasive. Based off your assessment, he may have to do something. He may have to drill a burr hole into this patient's skull to get a true reading. So it may be an intraventricular catheter. It may be a subarachnoid screw or bolt. Okay. It may be a subarachnoid screw or bolt. It may be a epidural or subdural sensor. Whatever method they decide to use on this patient, you know that you need to monitor this patient for hemorrhaging and infection. All right. Now, who is a candidate for this such invasive monitoring? This is anybody who has manifestations of increased intracranial pressure. That may be someone who has a low Glasgow Coma scale. It may be a patient who is posturing, decorticate, or disseparate posturing. All right. This is maybe the reason why the patient has to have this monitoring. It may be a patient who has a head injury and now is showing signs and symptoms of Cheyne Stokes. Yeah, car crash. It's not only a car crash, but they're also having increased cranial pressure. So they're having increased cranial pressure. All right. So you can have meningitis, but what if you don't have increased cranial pressure just yet? What if the meningitis is under control? You see? So when you have these patients who have these neurological injuries, we are monitoring the patient, because if this patient starts to show posturing, dilated pupils, pinpoint pupils, Miss Jenny, then we know that this patient is going to have to probably get these different intracranial monitoring devices inserted. All right. But that's good. Yeah, meningitis. And so pre-procedure, what do? We shave and clean, right? Because we don't want any infection. Because we don't want any infection. So we shave and we clean, because we don't want our patients to have any type of infections introduced into the incision. All right. We shave and we clean. We shave and we clean. Pre-procedure. All right. We keep this closed. All right. We make sure that this maintains a closed system. And during the procedure, guys, guess what? We're still checking that Glasgow Coma scale. We're still checking it. Intra-procedure, we are still doing our neuro checks, and we are still doing our Glasgow Coma scale. And we have to make sure that everyone uses surgical aseptic technique. If I have to go to the supply room myself, I'm going to the supply room myself. Surgical aseptic technique. And post-procedure, most importantly, guys, post-procedure, that patient is going to be with you. So you are still monitoring for signs and symptoms of increased intracranial pressure. You are watching that monitor like a hawk. Okay. You are making sure that this system does not become contaminated. You are keeping a closed system. All right. And you want to limit this procedure for 3 to 5 days. All right. 3 to 5 days. Okay. And you are vigilant about the interpretation of findings. Remember, 10 to 15 millimeters of mercury, guys. And you are watching for infection and bleeding. All right, guys. That is it. So Monday, I'll show you guys a Glasgow Coma scale. All right. Glasgow Coma scale. All right, guys. That was great. Thank you for joining me. All right. And the PowerPoints are in the description box. And I will sing you guys. Also, if you want the video, I'll put a video of Cheyne Stokes. I have a really good video of Cheyne Stokes. I'll put that in the description box, and the death rattle in the description box, so you guys can see it. Okay. Sometimes, it's better to see it. All right. Good night, guys. And I will see you guys on Monday. Monday. I'll see you Monday. You're welcome, guys. You're welcome. I'll see you then. All right, guys. Good night. You're welcome. Good night. Good night.